Good morning, good afternoon, whichever time zone you're in. I'm speaking to you from California, and today I'm going to start us off, and then Carolina will join in the middle. We're talking about digital and health access for agricultural workers and their families. So mainly what we're going to focus today is on the development and findings from two new supplements to the National Agricultural Workers Survey. The first supplement was a digital access supplement, and the second was a HRSA-sponsored preventive health supplement. All right, for those of you who are not familiar with the National Agricultural Workers Survey, it's a national survey of crop workers that was started in fiscal year 1989. It has an annual random sample survey of 1,500 to 3,000 workers, depending on our funding. And it's what's called an establishment survey. That means that we contact workers through their employers. Our interviews actually go to farms and ask farmers for permission to select a sample of their workers. We do this because it would be prohibitively expensive to compile a list of all the housing locations that farm workers are in, including all this unusual housing, such as sheds or trailers in the backyard or things like this. So we feel like we get a better sample of farm workers using an establishment survey. The survey is a reliable source of information on crop worker demographics, and we have limited regional coverage and no local numbers. And that's because of our sample size. So for example, if you think of having 1,500 to 3,000 workers sampled, that's between 30 and 60 workers per state. So clearly we can't say very much about a state, and within a state, much less about a county. So, and currently we do not interview H2A workers. So I want to talk a little bit more about the NAWS sampling universe, who's in, who's out, based on the migrant and seasonal agricultural worker definition that HRSA uses, which Carolina will talk about a little bit later. So let's see. So we're talking about currently employed, sorry, I got a strange message on my screen from the conference. All right, so our sample includes currently employed workers. That is, they have to have been employed in agriculture in the last 12 months so we could visit their employer and interview them. The workers have to be domestic because we're only interviewing inside the United States, and we only interview crop workers. But that includes crop workers who are hired directly by agricultural producers, as well as those that work for farm labor contractors. And on our questionnaire, we ask about the family members of folks in this group. We do not include in the survey at this time formerly employed agricultural workers, if you haven't, because you don't have an employer for where we could find you, H2A workers, livestock workers, and aged or disabled workers who are no longer in the crop labor force. And we also don't collect information on family members of those groups. So Patricia, as we're going through, if you get clarifying questions in the chat, let me know. More general questions we'll save for a Q&A session. All right, so I'm going to be talking about the NAWS migratory streams today. And this is how we define them. Everyone has their own definition of the Eastern, Midwest, and Western streams. So if you're in a green state today, then you're in the Eastern stream. If you're in a yellow state, you're in the Midwest. And if you're in the Western stream, you're on one of the orange states. So altogether, we have data from 2018 to 2020, and we have 3,520 respondents, of which a little over 2,000 are in the Western stream, about 550 are in the Midwest, and almost 800 are in the Eastern stream. All right, before I start talking about findings, I just want to put up a few national numbers. Sorry, I'm getting these strange messages on my screen. All right, so when I say national, what I'm talking about is the continental US, not Alaska or Hawaii. And then sometimes you'll see estimates marked with a superscript A, and those mean that they should be interpreted with cautions because they have a higher variance than we would like. And then sometimes you'll see the letter B, and you'll see no number. And that's because we've suppressed a value because it's based on 4 or fewer people, or that it has a very large variance, and so we consider it unreliable and don't report it. All right, so now I'm going to talk about the digital access supplement. So in developing the digital access supplement, we kept several things in mind. The first was the purpose of the supplement, which was to provide key information about broadband access and digital literacy in the United States for migrant and seasonal farm workers and their families. Our content areas were access to digital information, types of digital devices used by the farm worker spouse and children in the household, and farm workers' use of devices for information about services, including health. We also thought about how the data would be used, and we wanted it to be used to support the development of technology-based products, so apps, websites, mobile processes that would reach and assist migrant and seasonal farm workers and their families in the areas of safety, education, training, healthcare, housing, and unemployment. We also wanted to make sure that the supplement had synergies with other data. So you'll notice that the question, or you may not notice, but I'll affirm that the questions in the supplement either parallel or complement surveys in other national and international surveys on digital access. All right, so before I get started, I'd like to just set the scene a little bit. So why we did this was because that there was a lack of national studies on digital access. There were important prior studies on agricultural workers' digital access, and they provided critical information. However, at the same time, the studies were generally small, geographically limited, sometimes qualitative, and done at different times. And those are the authors and years that the studies were published in case you want to go look for them, because the slides will be available. The Pew Hispanic Research Center regularly conducts national surveys and has several interesting findings, 3 of which I want to talk to you about right now. One is that Hispanics are more likely than whites to rely on their smartphones for a number of activities such as seeking health information or looking for work. Also, Hispanics express pronounced interest in getting training that would help improve their digital skills. Some 48% of Hispanics say training to help them be more confident in using computers, smartphones, and internet would help a lot. And this is compared to 20% of whites. Finally, in the 6 years between 2013 and 2019, ownership of desktop and laptop computers declined among Hispanics from 72% to 57%. And at the same time, ownership of smartphones increased from 49% to 79%. So a greater reliance on smartphones. All right, so the first question that we asked was, do you or anyone in your household have access to digital information sources? And 95% of the farm workers that we interviewed said, yes, I do. They said that 87% of their spouses had access and 73% of their children. So access is pretty high. When we asked about what devices they were using to access, we can begin to see differences in how people are able to obtain digital information. So cell phones are incredibly popular, right? 92% of folks had smartphones that were cell phones, so cell phones that had internet connections. 96% had text. So these are great ways to contact farm workers. On the other hand, fewer than half of farm workers had a computer, only 41%, and only about a quarter of the farm workers we interviewed had a tablet. So again, if you're going to try to communicate with the farm workers, it needs to be able, whatever you're putting out there needs to be able to be accessed via a smartphone. All right, or text. So in terms of spouse having access to devices, again, this was lower, it was 87%. We see that there was cell phone with internet, so smartphones was 92%. You'll see that that's larger than saying they have access to digital information. And this is really interesting because I'm not sure what that means to people. And that is the question we might discuss in the discussion section. However, at the same time, for spouses, computers and tablets are much lower use. So 44% had access to a computer, 28% had access to a tablet. For children, So 73% of children had access to a digital device, and 79% had access to a computer. So maybe some of those computers aren't connected to the internet. Cell phone use was actually a little bit lower than computer access at around 3/4, but all three of them were sort of around 3/4 of children. And tablets were right around 50% or half, a little over half of children had access to a tablet. All right, so in terms of looking at children's computer access by age, you can see that as the children get older, their access increases. So children who are younger than 6, 75% of them had access. Children who are ages 6 to 13, 80% had access. And children ages 14 to 17, 87% had access. All right, so we also asked, have you received help to use a digital device to, something is flashing on my screen and it covers part of my screen for me. Let me try again. Have you received help to use a digital device to seek or obtain information on employment, health or health insurance, training or education, benefits, housing, or childcare? And you can see here that the most common thing that people looked for was employment. So 19%, which is almost 1 in 5 farm workers, 17% accessed health or health insurance information, and that's about 1 in 6. And then 1 in 8, or around 12%, accessed information on training, benefits, or housing. And only 3% accessed information on childcare sources using digital information. So again, while farm workers have the devices to access digital information, they're not using them very much for these kinds of, to seek or obtain services or for employment. All right, there's often a thought that farm workers need help to use their digital devices. So we asked whether they had done it by themselves, received help from a spouse, or from children. And you'll see that very high percentages of farm workers said that they did it by themselves when they were seeking all the different kinds of benefits. They did say that they had help from spouse occasionally, and more often about 20 to 25%, or 1 out of 5 or 1 out of 4 farm workers, for looking at health insurance or health information, benefits, and childcare. So to me, that indicates that while they are able to get the information themselves, these may have been joint decisions, and so 2 people were looking, or they were doing it in a joint format. All right, so I'm going to talk about different digital access within the agricultural worker population. But before I start, I just want to check in. Patricia, do we have any questions that I should take now, clarifying?
Hi, Susan. No, at this time, we do not have any questions.
Perfect. All right, great. So now I'm going to talk a little bit about differences in digital access by stream. And now I'm going to be fitting more stuff on my slides. So the slides are going to get a lot busier. However, what I'm going to encourage you to do is to not worry. I'm going to tell you everything on the slide that you need to see, but I'm putting the numbers on the slides because you'll be able to download them and access them later as a reference. So here's digital access by stream. We can see that the percent of farm workers in each stream that said they had digital access was exactly the same. It was 95%. We see, we looked at differences in digital access by age, and you can see what we expect, which is that farm workers over the age of 55 have a little less access. So as age goes up, access goes down, right? So, but still 87% of farm workers over the age of 55 said they had digital access. And there was very little difference between those ages 14 to 54, with more than 95% of them having digital access. So when we look at differences by gender, you can see that it's also very, very similar. Men, 95%, women, 97%. All right, so we also asked a question about differences in access by primary language. So those who said their primary language was English or that they were bilingual Spanish-English speakers had very high rates of digital access, 97 and 98%. Those who said they were monolingual speakers of Spanish or some other language that was not English, they had digital access of 94 to 96%, so just a tiny bit lower. But those who said that their primary language was an indigenous language, 75% of them said they had digital access. So that means that a quarter of all the people who answered our survey who were indigenous did not have digital access. All right, so we looked in terms of household composition, and there's not much difference in terms of household composition. Parents and singles, 95, 97%, and those who are married couples without children have about 91%, but all households, it was over 90% digital access. And if we look at migrants versus settled, we see that digital access itself is very similar, 93% for migrants, 96% for settled farm workers. And we also looked to see if those who had a chronic condition had differences in digital access, and it's not. We have 95% of people have digital access whether or not they had a chronic condition. All right, and my slides are getting a little repetitive, but this will get more interesting when we get to digital devices. So we looked at those that used healthcare versus those that didn't use healthcare. And we looked at those that went to a migrant or community health center versus those that did not. And in all those cases, digital access was just about the same, with about 95, 96% of farm workers saying, yes, we have digital access. All right, so now, again, the slides are going to get a little busier because we're going to be talking about devices. So if you look at this screen, we're looking at digital devices by migrant streams. And we're going to see here that digital access is lowest in the Western stream. About a quarter of people have a tablet, about a third of people have a computer. And for these devices, you'll see that the tablet percentage is very similar in the Eastern stream, about a quarter, but close to half of folks have a computer. Whereas the Midwest is the area where we see the highest digital access, with almost 4 in 10 people having a tablet and 6 in 10 having a computer. Now, access to smartphones and cell phones with text is very similar across the streams, very slightly less in the Western stream, with smartphones at 91% and cell phones with text at 94%. All right, so we're looking again about over our age categories. And what you're seeing is that that smartphone access is pretty high across all groups of folks who are between 14 and 40. It goes down a little bit between 41 to 54, with only 90% having a smartphone, and down to 82% for those over the age of 55. But what we see is a big difference in computer access and tablet access. And that goes pretty much as you expected. The younger you are, the more likely you are to have access to a computer or a tablet. So whereas youth ages 14 to 20, 70% have access to a computer, and slightly more than a third have access to a tablet. By the time you get to those 55 and over, only 20% have a tablet compared to 36% of the youth, and 30% have a computer compared to 70% of youth. So if you're aiming for youth as your target market, you're going to do a little bit better on devices other than smartphones. But if you're looking at folks 55 and over, you're pretty much limited to a smartphone. All right, so we're looking at devices by gender, and there really is no gap between men and women in terms of access to a device. So we see that again, smartphones for men, 92%, smartphones for women, 93%, tablets about a quarter. There's a little bit of difference in terms of computer usage, with men having computer usage at 43% and women at 38%. So very similar. again, if we look at primary language, this is where we see a difference. So we have, again, we have more digital access, more computers, more tablets if you are English speaking, slightly less if you're bilingual Spanish English, and if you're less if you're a Spanish monolingual speaker, followed by those who speak other languages. And when we get down to indigenous folks, though they say that they have 75% have access to digital information sources, cell phone with internet is at 86%. And we got so few responses about computer and tablet that they're not reportable. So we see that it's at the device level that we really see more of a digital divide than when we were looking at this. This could also be that because there are written forms of some indigenous languages are not available. So that could definitely put a crimp in this. You would need to be doing stuff by video or audio. So, all right. So if we're looking by family composition, again, we see that interestingly, it's a little more pronounced now than digital access to digital information, but married couples who have no children have less computer access than parents, and singles have the highest computer use with about half or 50%, and parents at about 40%, and married couples at 34%. So again, we see a little bit more difficulty communicating with married couples without children. And now when we look at migrant status, we see again that there is a little bit of a difference. There was almost no difference in terms of digital access, but in terms of devices, we see that they're a little bit less likely than settled workers to have computers, and there's a few percentage points less likely to have a smartphone. So migrants at 89%, settled farm workers at 93%. And also those with chronic health conditions, we see that there's really no difference in inability to use a digital device like a computer, a tablet, or a smartphone between those who do and do not have access to devices. Oh, sorry, do and do not have chronic health conditions. All right, so we're looking at the people who said they used digital devices for healthcare compared to those who didn't. And those smartphone usage is pretty close. 93% of those who accessed healthcare information had a smartphone, and 90% of those that didn't. But computer usage is up at 45% for those who used who used a digital device to access healthcare information, compared to 35%. So a 10 percentage point difference between the two groups. So if you had a computer, you were more likely to have used it to access healthcare information. All right, so this is the not so good news, right? So we saw that there's very little difference in terms of digital access between those who went to a community migrant health center and those who didn't. But we see that there's a big difference in access to digital devices. So those who did not go to a community health center are 4 percentage points higher. So they're 95% have smartphones versus 91% for a migrant and community health center. Big differences that we see are in tablets and computers. So whereas only a quarter of the those who health center patients had tablets, a third of those who saw other providers, and 29% of patients who were surveyed by us had computers, compared to 56%. So not quite, almost double, but not quite double the percent having a computer. So if you're in a community health center and you want to communicate with your patients, you're going to be looking at smartphones. All right, so that's it for the digital supplement. Patricia, do we have any questions at this point?
Yes, Susan, just real quick. Someone asked if it'd be possible for you to slow down just a tad
Oh,
And
yes.
then, so as we speak, and then also there was a question regarding the article of study, if there will be a link to the article so that participants can access it, or where they can find that article.
Let me make a note. We do have references for all of them, and I will figure out from the conference organizers how to post the references. So I will find that out. But
It
yes,
looks like we have, go ahead.
I can get that information to you guys to give to folks who would like it.
Excellent.
Go ahead.
There's another question here. For people that did not go to the community health center, were they receiving health care somewhere else or not at all?
That's a great question. And we're going to be talking about that in the HRSA health supplement. So I'm going to, if it's okay to hold off on that, we have a slide on that coming up.
Okay. Another question just popped up. Why are H2A workers excluded from NAWS?
Really good question. We are in the process of doing a feasibility study to add H2A workers to the survey, and we are hoping that maybe next year or the year after we'll have H2A workers. It's a historic thing that came up at the Department of Labor because H2A workers, it's the government. H2A workers and non-H2A workers are in different departments at the Department of Labor. And it was felt that there was enough information about H2A workers that more information wasn't needed, but now that's changed and we're working in collaboration with the Office of Foreign Labor Certification.
Okay. And another question is, did you look at country of origin?
Yes, we did look at country of origin, but I don't know the results off the top of my head. I could get back to the questionnaire if I could get back to the questionnaire.
Okay, I will jot down their names.
Yes, we're writing a paper on this and looking at this, and for that we did look at country of origin.
Okay. And then the Trump administration began to block the publication of data on the federal government level. How has this affected NAWS public availability? Are there plans to remove that executive order?
I don't know that executive order ever applied to us, but we are in the process of putting up our 2017-18 report and public access data up through either 2018 or 2019 this month. So there will be a refresh on our website. And so we should have products coming out more often. I think that's being pushed a little bit along by the Farmwork Modernization Act being introduced in Congress because we're getting a lot more requests for information. So just keep looking. My slides are available for the conference, so you can download those. Go ahead. Anything else?
And yes, what is the possibility of getting NAWS data at the county level?
None. We don't even go to all counties. So NAWS data we cannot release county level information. I don't think there's a county in the country where we do enough interviews to have a county level sample.
I think that's all for the questions.
Perfect. So Carolina is going to talk for a while, and then when I come back, I will talk slower. So, all right. Carolina, do you want to, I will stop sharing.
All right, great. Well, thank you so much, Susan, and thank you for the opportunity to speak with you all today. Again, I'm Carolina Loyola, and I'm an epidemiologist with the HRSA Bureau of Primary Healthcare. And before we transition, I do want to acknowledge the importance of better understanding digital health access for agricultural workers for HRSA as well. It's very important to HRSA, and we're always looking for ways to increase access to care, like expanding the use of telehealth visits, which has proved particularly important in the last year during the COVID-19 pandemic to ensure access and reduce barriers. So these are the learning objectives for this segment of the presentation. And by the end, I hope you'll have an improved understanding of the mission and population served by the Health Resources and Services Administration and the Health Center program, how data from the National Agricultural Workers Survey, or NAWS, complement and support HRSA and health center activities, and how HRSA and the health center program use NAWS data along with other data sets to better understand the migratory and seasonal worker populations they serve and perform related activities. I'd like to start with a brief overview of HRSA and the mission of the Health Center program to illustrate why the partnership between HRSA and the Department of Labor for the NAWS is so important. HRSA supports more than 90 programs that provide care to people who are geographically isolated, economically or medically challenged through grants and cooperative agreements to more than 3,000 awardees. Each year, HRSA programs serve tens of millions of people, including people living with HIV and AIDS, pregnant women, mothers and their families, and those otherwise unable to access quality health care. Similarly, the mission of HRSA's Health Center program is to improve the health of the nation's underserved communities and vulnerable populations by assuring access to comprehensive, culturally competent, quality primary health services. As part of the Health Center program, health centers must serve a high-need community or population. They have to deliver high-quality, culturally competent, comprehensive primary care, as well as supportive services like health education, translation, and transportation that promote access to healthcare. They must provide services regardless of a patient's ability to pay and charge for services on a sliding fee scale. They must also operate under the direction of patient majority governing boards of autonomous community-based organizations and develop systems of patient-centered and integrated care that respond to the unique needs of diverse medically underserved areas and populations. And also they have to meet requirements regarding administrative, clinical, and financial operations. The Health Center program has nearly 1,400 health centers and 13,000 service sites, delivery sites across the US, and serve nearly 30 million patients. And the image on the bottom right gives you a sense of the distribution of health centers and their delivery sites across the country as of December 31st, 2019. As you heard earlier today, of the nearly 30 million patients served at HRSA-funded health centers, over 1 million include agricultural workers. Some health centers receive funding to focus on special populations, including migratory and seasonal agricultural workers. And those particular health centers are required to provide services to a statutorily defined target population. For the purposes of the 330G Migrant Health Center program, the target population under migratory and seasonal agricultural workers is defined as follows. Migratory agricultural workers are individuals whose principal employment is in agriculture and who have been so employed within the last 24 months and who establish for the purposes of such employment a temporary abode. Seasonal agricultural workers are individuals whose principal employment is in agriculture on a seasonal basis and who do not meet the definition of a migratory agricultural worker. It also includes individuals who are no longer employed in migratory or seasonal agriculture because of their age or a disability, who are within such a catchment area, and family members of the individuals previously described. The HRSA Bureau of Primary Health Care and the Department of Labor, Employment, and Training Administration have a long-standing partnership, and since FY 2007, HRSA and DOL have had an interagency agreement, or IAA, with the purpose of combining HRSA and DOL resources to improve survey and analytical services and reports regarding the National Agricultural Workers Survey, or NAWS. The IAA provides HRSA with access to NAWS analyses and resulting findings, and in concert with DOL, ETA, and other NAWS stakeholders, the opportunity to take the lead in identifying and prioritizing future health research domains for the survey. And because of the similarities between the target populations of the NAWS and the health center program, there is a great degree of awareness between the two operations. HRSA's goals for the expanded health questions, which you'll hear more about in the last portion of our presentation, include to enhance HRSA's ability to understand the barriers farm workers and their families face in accessing comprehensive, affordable, and culturally and linguistically effective healthcare services, and to inform and enable HRSA to undertake outreach focused on expanding farm worker access to such comprehensive health services. And just as a note, an expansion in access to health has implications for healthcare utilization, as previous research showed that having health insurance makes medical care more affordable and accessible. So how does HRSA use the NAWS data? These data inform diverse activities like making informed decisions at federal and non-federal technical working groups, assessing barriers to healthcare and learning about the quality and access to healthcare, making informed decisions about the expansion of healthcare services, as well as new access points, funding awards for health centers, and also formulating recommendations to the Secretary of Health and Human Services via the National Advisory Council on Migrant Health, also known as NACMH. So the NAWS data are also used by HRSA's National Training and Technical Assistance Partners, or NTAPs, which provide training and technical assistance to our health centers. And more specifically, NTAPs use the NAWS data to identify health and demographic characteristics of migrant and seasonal agricultural workers, patterns and trends in health status, and the effects in health services in order to create TA resources. They are used to also develop targeted training and TA that is needed to keep migrant and seasonal agricultural workers and their families safe, especially given the unique challenges that they face during emergencies like the current COVID-19 pandemic. And finally, also to present relevant NAWS findings at HRSA-sponsored agricultural worker health forums and conferences. So now I'm going to shift focus and talk about different data that HRSA uses alongside the NAWS. As part of the program requirement for participating in the health center program, health centers are required to annually report data on the number and types of patients served, services delivered, staffing profiles, and financial information, as well as the number of clinical performance measures and health outcomes aligned with national quality efforts. This annual data collection is known as the Uniform Data System, or UDS. And HRSA uses these data to monitor trends in health center performance, generate reports on program outcomes, to better understand grantees' financial health, tailor TA, and respond to thousands of inquiries that are received each year. While HRSA has a fairly robust data collection activity, thanks to the UDS, the information provided to HRSA comes from organizational records like patient charts and billing, and do not represent important patient perspectives. In addition, HRSA data only represent migrant and seasonal workers that are already receiving care in health centers. The NAWS provides a more robust picture of agricultural workers, including those who are currently seeking care at health centers, as well as those seeking care at other settings, or those who may not be obtaining health care at all, even if they have health care needs. I'd also like to note that the Health Center Program awardees receiving Section 330 grants under multiple program funding authorities, including the Migrant Health Center Program, are required to complete a separate UDS report. Now, beyond the UDS, similar data collected in the NAWS are also captured in other national surveys. These nationally representative surveys listed here will be used to compare health-related and sociodemographic insights drawn from migrant and seasonal agricultural workers from the NAWS with the rest of the US population. So this includes the National Health Interview Survey, the Medical Expenditure Panel Survey, the National Health and Nutrition Examination Survey, and the Health Center Patient Survey. Okay, so now that I've had the opportunity to talk a little bit about HRSA and the Health Center program and the importance of the partnership between HRSA and the DOL for the NAWS data collection, and also provide some highlights regarding HRSA's use of these very important data to inform our work, I'm going to hand things back over to Susan to talk in greater detail about the expanded health questions. Thank you so much.
Great. Thank you, Carolina. Let me. All right. Perfect. All right. So I'm going to try to speak a little bit slower. I get very excited about this information. I think that the HRSA sponsored supplement and the digital access supplement are very exciting new kinds of information. So, but before that, I'm going to talk a little bit about health insurance, because I'm going to refer to health insurance when I'm talking throughout the information from the supplement. So, as this is a time trend graph that shows the percentage of farm workers having health insurance from 2000 through 2020. And you can see that in 2020, 89% of children have health insurance, 56% of spouses have health insurance, and 48% of the agricultural workers. And this, you can see that this pattern of has stood for the past 20 years, or well, we only started collecting information on children in 2006. So, but generally, spouses have more access to insurance than the agricultural workers, and children most children have insurance, but an important 1 in 10 do not. So what is the source of health insurance for farm workers? So since the Affordable Care Act was enacted, the main source has been government programs. And government programs refers to expanded Medicaid, regular Medicaid, and subsidies on the exchanges. So we can see that this is the main source for farm workers at 38%, spouses 43%, and children 83%. In fact, government programs make up most of the insurance that children have. A small percentage of children have access through their parents' employer. And when we look at farm workers, we find that employers are the next most important source of health insurance. So currently about a quarter of farm workers have employer-provided health insurance, and the numbers of spouses who have their own employer. So spouses' employer insurance is the same thing. It's around a quarter at 27%. So smaller amounts of insurance come from either the spouse or the worker being on the other's employer health insurance. So 14% of spouses are covered by the farm workers' employer-provided insurance, and 7% of farm workers are covered by their spouse's employer's insurance. And then for the farm workers, a group of farm workers who are under age 26 are covered under their parents. So a lot of youth and farm workers who have health insurance have it through a parent's insurance. All right, so let's see. So I'm looking at this across the streams, and you'll see the patterns pretty much hold, though the values are a little different. So in all streams, farm workers are less likely to have insurance than their spouses, and farm workers and spouses are much less likely to have insurance than their children. So what we see is the stream that has the highest levels of insured workers and household members is the Midwest, where 83% of children have insurance and about 2/3 of farm workers and spouses. The place where we see the least insurance is in the Eastern stream, where we have about 40% of farm workers have health insurance, 45% of spouses, and 87% of children. And the Midwest is in the middle. All right, so now I'm going to talk about the health supplement itself and how the health supplement expands what we know about agricultural workers' health. So first, I'm going to start by talking a little bit of comparing our old and new questions. So on our previous, before the 2018 supplement surveys, we asked a question, which is, have you visited a healthcare provider in the last 2 years? So for the supplement, we changed this to in the last 12 months. So the 2-year survey results are the blue line, and you'll see they go from 36% in 2000 up to 63% in 2016. Currently, in the last 12 months question sits at 65% for 2020. And so, but we don't really know whether there was a jump there or what happened, because we're not collecting information on visits in the previous year. So I just want to point this out for people who use this information from our survey. Okay, so healthcare visits for routine or preventive care. Yes, so perfect. So the really exciting part about this health supplement was that we asked farm workers, and we asked them about themselves, their spouses, and their children, whether they had had a visit to a healthcare provider in the last 12 months for 4 different types of services. So we asked for routine or preventive care, we asked for illness, we asked for injury, and we asked about dental care. So we can now, talk about these separately. Sorry, turning my camera back on. All right, so in terms of routine visits, 57% of farm workers had had a routine or preventive care visit, 61% of spouses, and 76% of children. So these are better numbers than we likely had in the past, but they're not great numbers, because we have 1/4 of children did not go, 40% of spouses did not go, and a little over 40% of farm workers did not have a routine visit. Now, of those who had a visit, 68% of the workers, 70% of the spouses had insurance, and 78% of the children. And the top 3 providers, this answers the question that was answered earlier. The top 3 providers for a routine or preventive care visit were a private clinic or doctor's office. So 53% of those who went, so 53% of the 57% went to a private clinic or doctor's office. So a little over half, and then a little under half went to a community and migrant health center at 44% and 46%. 3% of farm workers, spouses, and children had a routine or preventive care visit that they said was at a hospital. And so we asked, why didn't you have a visit? And the top 3 reasons that we got for not visiting were no need to go, doesn't get sick, and that was 82% for the workers, 90% for spouses, 90% for children, and people were allowed to select more than one reason for no visit. So about 1/4 of the farm workers said that the visit was either for no insurance or it was too expensive. So again, so we have 3 issues in terms of getting farm workers to get their preventive care, right? They don't think they need it, and too expensive. And we asked the farm workers some questions that were not asked of the spouse and children. So we asked the farm worker, who were the top payers for the visit? So the top payers for farm workers routine or preventive care visits were Medicaid at 21%, out of my own pocket at 18%, employer provided health plan at 17%, and public clinic did not charge at 15%. And farm workers said that they were very satisfied 93% of the time with their preventive care visit. Now, in other surveys that I've done, farm workers are very likely to say that they are very satisfied with whatever they get. This is a population that reports very high satisfaction. They're very polite about it. So one of the things that you might want to look is, instead of focusing on the level, look at the differences in terms of saying they're very satisfied for the different kinds of visits. All right, so we also asked about illness, and about 16% of farm workers said they had to go for an illness, 20% of spouses, and 16% of children. And so of those who went for an illness visit, we have very low insurance rates here. So 17% of the 16% said they had insurance, 22% of the 20%, and 17% of the 16% had health insurance for those visits. The top three providers, again, were the private clinic or doctor's office at about 40% for both the worker, the spouse, and children. Also, about a third went to the community and migrant health center. So 32% of the workers, 36% of the spouses, and 32% of the children. Hospitals were much higher on the list at 18% of workers, 15% of spouses, and 9% of children. However, you have to realize, again, this is 18% of the 16%. So that's about 3 or 4% of workers, spouses, and children going to the hospital for an illness visit. The top three reasons, or the top most important reason, was that they didn't need to go. They didn't get sick. And then also no insurance and too expensive were additional reasons that some people checked. All right, so if we look at who paid for the illness visits, Medicare was the top payer, followed by out of my own pocket, then employer provided health insurance, and self or family bought individual health plan. So farm workers said they were 85% satisfied with these visits. And more people selected somewhat satisfied than very satisfied compared to their routine or preventive care visits. So now I'm going to move on to looking at the injury visits. So injury visits were pretty rare. So there were 6% of farm workers had an injury visit, 4% of spouses, and 2% of children. And of those, the percent that had insurance was tiny. So 6% of the 6% had insurance. So now if we're looking at the top three providers, we see that it's the private clinic or doctor's office, followed again by the community migrant health center, followed again by the hospital. And the hospitals were more likely to send people were more likely to go to the hospital for an injury than they were for illness or preventive care. And the reasons that they didn't go were they didn't have an injury, they didn't need to go, or a small percentage said that they had no insurance or too expensive, indicating they might have had an injury that they would have liked to have gone, but refrained from going. So when we asked who the top payers for the visit were, the top payer for farm workers is workers' compensation. So clearly a good portion of these accidents were related to farm workers' work activities, because farm work is, like I believe, the second most dangerous occupation in the United States, right after mining, followed by employer provided health plan, followed by self or family bought plan, followed by out of pocket. And 87% said they were very satisfied with their injury visit. So now we're going to look at dental care, and this is very exciting because we have been able to look at medical visits and ask about them, but we've never been able to fully separate out dental care and ask about dental care for farm workers, spouses, and children. So in terms of a dental care visit, only about a third of farm workers said that they had a dental care visit, compared to about 40% of spouses and 2/3 of children. And this is important because we know how often you should be going to the dentist, right? You should be going every 6 months. And so not having a visit means that there was something that should have happened that didn't happen. So 2/3 of farm workers do not go to the dentist. This is a pretty high number. And of those who went, 44% had insurance among the farm worker and spouses, and 69% of the children. Now, where did they go for these visits? So about 3/4 of them said they went to a standalone dentist office, right? And then another 25%, so for the worker, it was 17% went to the private clinic or doctor's office, and 8% went to a community or migrant health center. So about 25% were going somewhere where there was integrated medical and dental care. The top 3 reasons for no visit was: I didn't need to go, I didn't get sick. So there is a tremendous outreach opportunity right there. 21% said it was too expensive, and 16% of farm workers said it had no insurance. And very high rates of saying that the children who didn't go to the dentist had no need to go to the dentist, and spouses as well, at 96%. So that's a pretty high number of people saying that they don't think that they need regular dental care. We also asked about who paid for it, and the top payers for dental care were out of my own pocket, followed by self or family bought individual health plan, followed by Medicare, Medicaid, and then employer provided health plan. When we asked farm workers about their satisfaction with their dental visit, it was 91%. So I'm sure you guys have not been tracking this, but 93% said they were very satisfied with their routine or preventive care visit, and 91% with the dental visit. So it seems a very high satisfaction rate for routine or preventive care. And then the rates for illness and injury were in the mid to low 80%. All right. So I'm going to look at differential health access within agricultural worker population. So again, we're going to have some busy slides, and I'm going to be telling you what it is you need to know on them, but all the numbers are here so that you can download it. All right. So, at the top, we have had any kind of a medical visit. So any visit, and this time we're excluding dental. So we had 65% in the Eastern Stream, 72% in the Midwest, and 61% in the Western Stream had some sort of medical visit. It looks the similar pattern for preventive visits, where it's higher in the Midwest, followed by the Eastern, and then lower percents in the Western Stream. The rates of illness and injury are fairly similar, that they range from 14% to 19% across the regions, and for illness and injury ranges from 5% to 7%. And in terms of dental visits, we see that the Midwest is also ahead. 41% of workers in the Midwest had a dental visit, compared to about a third of workers in the Eastern and Western streams. When we look at age differences, we see that a pattern that we expect, which is that the older age groups, those 55 and over, are more likely to have had a medical visit. Those 14 to 20, that young people edge out, have one of the highest percents, which is 63%. And then the rest of them are somewhere in the middle. My guess about the 31 to 40 year folks having a slightly higher rate is those are people who have families and they are in childbearing age. So maybe more OBGYN visits, or just more visits because your kids are also going to the clinic. When we look at preventive care, again, we see older farm workers are much more likely, 2/3 of them are getting preventive visits. The lowest group for preventive visits is workers between ages 21 and 30, where only about a half, as opposed to 2/3 of the older workers go. The illness rates, as you would expect, go up a little bit over age, which is they range from 11% for the 14 to 20-year-olds to 20% for those over 55. And we'll talk a little bit more about illness later for this group. And also you can see that in injuries decline slightly over the years, and we don't know whether that's because farm workers get smarter at not having injuries or whether farm workers are doing less hazardous jobs as they age. And in terms of dental visits, we see that, again, it goes down over the course of the ages, with youth under 20, 50% of them going to the dentist. And for those over 40, only 29% are going to the dentist. So dental visits drop off with age. We looked at gender differences, and for any medical visit, women are more likely to go. 73% of the time, women had a medical visit versus 59% for men. Women were likely to go to preventive visits, 2/3, as opposed to 1/3 of men having a preventive visits. Their rates of illness and injury were pretty similar. However, women were also more likely to go to the dentist at around 40% compared to 30% for men. And when we look at primary language, we also see differences in access. So similar to digital access, those that are bilingual or English language dominant and actually also those who are other monolingual other speakers, non-Spanish speakers, have pretty high rates in 69 to 71. Monolingual Spanish speakers have 61% have a medical visit, so it's starting to fall off. And Indigenous language speakers, 29%. In the same pattern holds forth for preventive care, where English language and bilingual speakers and other monolingual speakers have higher rates in the 60 to 64% range. Spanish monolingual speakers at 55%, and Indigenous farm workers at a lower level, but one that's has a high variance, so we're not reporting it. In terms of illness, you can see that the rates are pretty similar, 14, 15, 16%. And again, there's so few numbers for the Indigenous that we can't report them. That population is pretty small within our sample. And injury rates are pretty similar, ranging from 3% to 7%. And here we go. All right, so for dental also stepping stones. English language, folks with English as their primary language, 46% dropping to 39% for bilingual speakers, down to 28% for Spanish monolingual speakers, and 17% for Indigenous workers. In terms of family composition, we see that parents and married couples are more likely to have had a medical visit than singles, and this holds for preventive visits as well. We see reasonably similar rates of illness and injury, though a different pattern holds for dental, where singles and parents at 35% going to the dentist, whereas 29% of those who were married with no children. All right, so we're looking at differences by migrant status. So here we do see big differences, whereas less than half of migrant workers had a medical visit, 2/3 of settled workers had a medical visit. For preventive care, again, 40% of migrants having a preventive care visit, as opposed to 60% of settled workers or seasonal workers, whichever you want to call them, non-migratory. When we look at illness, settled workers are a little bit more likely to have had an illness visit. I don't want to make too much about the difference in injuries because that's 3% versus 7%. But again, down here, we see a difference in about a quarter of migrants going to the dentist versus about a third of settled workers. All right, so when we look at differences by chronic health condition, perfect, we see that people who have chronic health conditions are much more likely to go to the doctor. And we don't quite know whether this is because, they've been diagnosed, they were sicker, they needed to be diagnosed, and whether those that have the 55% haven't had a visit, so that there's some people with chronic conditions in that group that haven't been diagnosed. But those who know that they have a chronic condition, 80% of them had a medical visit, 75% of them had a preventive visit, versus less than half of those who don't have a chronic condition. Similarly, about 30% of those with a chronic condition had an illness visit versus 10% for those who didn't. The injury rates are very similar, and the dental rates are very similar at about a third. All right, so I'm going to summarize the findings for you. So the NAWS Digital Access Supplement provides the first national look at farm workers' access to, summarizing the digital information. Previous studies did not provide a coherent view of agricultural worker digital access, as they were generally small, local, qualitative, and done at different times. Most farm workers have access to digital information. Farm workers' access is primarily through cell phones with text or cell phones with internet, with computer ownership being much lower, and a minority of farm workers did not have digital access, around 5%. Those without digital access tend to speak an indigenous language, be age 55 or older, or are married but have no children. Children's computer access was high at 79%, with 76% of households with children ages 6 to 13 and 14 to 17 having computers. I'm going to summarize now the health supplement findings. So the annual share of farm workers visiting a healthcare provider was 65%. The most common type of visit was for routine or preventive care, followed by dental care and illness. Farm workers were less likely to visit a healthcare provider if they were an indigenous language speaker, were a migrant, did not have a chronic health condition, were single or a youth living with their parents, or male. And for routine or preventive care, farm workers most often sought care at private clinics, community and migrant health centers, with Medicare, Medicaid out of their own pockets, and employer-provided health plans being the main sources of payment. About 15% went to a clinic that did not charge them. So spouses and children were more likely to go for routine or preventive care than farm workers. Dental visits were less common than medical visits, with 34% of farm workers and 41% of spouses visiting a dentist in the prior year. Dental visits were more common for children, and for dental care, farm workers most often sought care at dental offices and private clinics with out-of-pocket, self or family-bought individual health plan, Medicare, Medicaid, and employer-provided health plan being the main sources of payment. Farm workers whose primary language was an indigenous language, were a migrant, and or were male, were less likely to have dental visits. So now I am first going to open it up to Q&A, and then I have some discussion questions that I'd like to talk to the group with. And Carolina, if you want to come back on with video and audio, some of the questions might be for you.
Susan?
So, yes?
We had a couple of questions pop up. Do you want to wait till later to go through those?
No,
okay.
No, I want to take clarifying Q&A and any group questions, and then we'll have group discussion.
Okay. Someone asked if NAWS collects collected data in 2020 during the pandemic? And was the response rate similar to other years prior?
We did collect data during the pandemic. It was a very interesting experience. We had to cut short our spring cycle last spring because of the stay-at-home orders. But by June, we were back. And so last summer, we did go out. We collected our full sample of workers over the summer during the pandemic.
Okay, great.
We were able to go to every single region. I have staff. We run the COVID numbers in every county that we're visiting every day that our interviewers are there, and our interviewers are amazing people. They are like, today you can go here. Nope, sorry, tomorrow you're going somewhere else. Oops, nope, that one turned bad, so now you're going somewhere else. They were amazingly flexible about staying away from home for longer periods of time and moving around as needed to keep themselves safe, and also wearing tons of PPE. So yes, we were able to do surveys during the pandemic. Great. Another question?
Yes. Can you speak to the type of insurance by the 3 regions?
Nope, but I can, not quite at the moment. Generally, what we say about regional health insurance is that I can actually add a slide for that, but generally the difference has to do with which states have expanded Medicaid. So in states where there's expanded Medicaid, then the government provides a higher share of the insurance for those that are insured. And for those in states where there's not expanded Medicaid, then it's generally employers who are bearing more of the burden of providing insurance for those that have insurance. And I can, I'm just writing myself a note here. I can, when I get the answer to the other question, I can put that back up.
Okay. Also, someone was curious if telemedicine made an impact on the rate of folks accessing health services.
We don't know. So for this year, starting in 2020, fiscal year 2021, we separated digital health access from health insurance from health information on the digital access. And we added questions about telemedicine. And we were going to start asking those questions, I believe, this June. We have a supplement that's going to ask some COVID questions starting this June. So we'll have information on that in the future, but right now we don't exactly know how people accessed their visits.
Right. The next question is, how does access for preventive care in this population compare to the general population? For example, the number who said they didn't think they needed it, how does that compare with the general population?
I don't really know. Carolina, do you have any idea?
No, I don't.
All right.
Off the top of my head either.
Okay. The next question is on illness visit rates. Do those vary by year? Example, COVID-19 2020 compared to other years?
That's a really good question. And we're going to go back and we're going to, as we get more data from the pandemic, then we will be able to answer those questions. It's part why Alfonso has a rapid assessment and is doing his own data collection, because it takes a little while to get the NAWS data. But we collected data last summer when the pandemic was in full swing. We collected data this fall up through through Thanksgiving, in which case it was unsafe for our interviewers to go anywhere. And we're back out now. So we're expecting to have more information on that next year or the year after when we look at this.
Okay. Next question is, when you said health insurance, are you including sliding fees from FQH clinics?
When we say health insurance, do you have health insurance? We're not including that. That is a separate question on, do you have insurance that would cover you if you had a medical visit? When we ask about the medical visit, yes, it could be including sliding fees, which is why I think that it says that, the public clinic, they did not charge. So, but we don't know if that's, I mean, we could cross-tab that and see if that was a migrant and community health center that didn't charge. But for, this is a great question, and we're just getting to be able to look at this stuff. So I'm going to look down, stop looking at you guys and write this down. So can you repeat the question for me, Patricia?
Yes, one moment. Okay. When you said health insurance, are you including sliding fees from FQH clinics?
All right, so we will go and cross-tab the information on payment with the information on where did you go. And so that is extremely interesting. We'll probably come back and tell you that information, but maybe next year because we don't happen to have that. So perfect. This is a fantastic question. Thank you. Again, you guys are the first people to see this data. It has been presented or published nowhere. So I'm really happy to get your feedback on this and hear what you have to say. So keep going.
We have 10 minutes to go, and we do have additional questions, but we could, since we're down to 10 minutes, maybe
I'd rather take audience questions than have you answer questions I thought up. Are you okay with that, Carolina? I mean, we said we would have discussion, but I've seen Zoom sessions where nobody does anything. So I had discussion questions. I even had breakout rooms, but I think I'd rather take questions from the audience because, again, this is new. So hearing what you're asking is very important, and it will shape our future presentations if we can't get back to you. And some of this stuff we can get to the conference organizers to answer your questions.
Okay. The next question is, for employer-provided insurance, does the employer pay for that, or is there a portion that workers have to pay?
Really good question. So we don't know what the share is who contribute to that. We only ask if it was, what is the source of your insurance? So is it employer provided? I would assume that when I talk to employers, it's most often there's a copay for the worker. It's why we have another question in our survey where we ask, does your employer offer health insurance? And those numbers are always a little bit higher than the number that tell us that they have employer provided health insurance, by which I think that there's lower uptake. So yes, we have it, but not everyone signed up. And that could be related to maybe possibly having to have a copay, but we don't know. It's a great question.
Next question is, in 2020, the alien emergency medical use rates went way up. Is there a correlating item in the NAWS data, or is it different? The government has interpreted the AEM numbers as farm workers, but not all farm workers are undocumented.
Yes, about half, at least more than half of farm workers are documented. So I don't know that I would be really surprised to say that it's all farm workers living in California, where we have a lot of people who aren't farm workers who would need AEM. And it's also very hard to know because in California, people who were not eligible for expanded Medicaid were educated, informed, and told to sign up ahead of time for AEM. So that was part of our state's rollout to get everybody to go to the California exchange, was that everybody was going to get something out of it, whether it was only AEM or whether they actually got expanded Medicare or a subsidized program. So I don't think that you could make that kind of a generalization about the AEM users, given how AEM was used in California and possibly, and I know New York also did a lot of promoting AEM.
Okay. Next question is any of this data broken down by state?
We can break it down for California and we can break it down for Florida, but we cannot break it down by state except in state regions. So we have regions that are like Northeast 1, Northeast 2, Washington and Oregon are our region. There's the Intermountain states are broken up between Northern Intermountain states and the Southern Intermountain states. And so we do have 6 public access reporting areas. which are California is the only state reported that, but we have 12 sampling regions, and Florida and California are separate states. Washington, Oregon are together, which is our only other 2-state region. We wish we had the sample size to do more, but we don't.
Next question is, on the questions for telemedicine going forward, will you ask questions on barriers to assessing telemedicine?
I don't think we have barriers to accessing telemedicine, but we do have barriers. So if telemedicine was a barrier, it might show up in our general barriers question. So this is something that this is in Carolina's department, not mine. It's HRSA and DOL are our content folks. We help them put together quality content, but they come up with our ideas. So I'm passing that along to Carolina to either think about or answer. Do you have anything more to say about how you thought about telehealth and NAWS data?
No, we haven't had a chance to talk about it recently, but I think that's a great question. And I'll definitely bring that back for the next round of iteration for the NAWS.
Yep, I think that we could probably talk about it because we're still having those questions reviewed by OMB. So it's a great time. So it's a great question.
Someone asks, will you be sharing all of your final findings to the NCFH anytime soon? And if so, by when?
Final findings being, these are preliminary findings. Final findings will go on the National Agricultural Workers Survey website, which is if you type National Agricultural Workers Survey into your into your browser, you should go there. It's on the DOL site. Do not type NAWS. You will get a National Alcohol something site. So do type out the name of the survey. And final findings will go up there. I work with NCFH all the time. I'm sure they'll have final findings at some point.
Okay, we have 5 minutes to go. One last question here that popped up. I am wondering in what parts of each state are NAWS patients participating? Because in the countries we serve, 70% of our patients are with the H2A program. Is NAWS patient participation public?
Okay, so so NAWS participate. So there are certain areas where we go where there are a lot of H2A workers, and that would be places like North Carolina, Georgia, and to some extent, Washington State starting now. But many other areas have much lower numbers of H2A workers. So I would say that H2A workers right now are edging up to be somewhere between 10 and 15% of the crop workers. And so 20% would be, so actually, so somewhere between 10 and 20% of the farm workers. And that's why we're doing the feasibility study, which I forgot to say is HRSA sponsored this year, to look at adding H2A workers to the NAWS. And depending on how the feasibility study goes and OMB goes, it could be as early as next fall that they're added. Otherwise, it might be another year. But we definitely notice the increased importance of H2A workers and plan to add them to the NAWS as we can.
I wanted to point out that there is a link in the chat to our survey. So before you head out, if you could please take a moment to fill that out. And also wanted to, before we log out, highlight and thank Northwest Regional Telehealth Resource Center for sponsoring this session. And if we have time, we have a few more minutes if you want to chat about any other questions.
No, I just want to thank everybody for being here. This is so great. Again, this is brand new data and your questions are excellent. And please let me know, or through NCFH, or my contact information was up there if you have more questions, because again, this is our first time showing this information. I'm delighted that I can share it more widely on Zoom, and also sad that we can't have more intimate Q&A where I could get more specific feedback, because I'd love to ask you all more about what you're doing with digital access and more about how our numbers compared to what you see were a lot of local and regional differences, as one questioner pointed out. So, Caroline, do you have anything you wanted to say in our last minute?
Just wanted to thank everyone for joining and for all the great questions. These are definitely questions that we're going to bring back and think about. So thank you so much.
Someone is asking what state you were from.
I'm from California, so Carolina.
I live in Virginia, but I'm originally from Chile.
All right.
And I think we're out of time.
Okay, great. Thank you, everyone. I'm glad we got this all in the right amount of time. Perfect.